Good afternoon. My name is Blair, and I'll be your conference operator today. At this time, I'd like to welcome everyone to the Living Well with Myeloma, Understanding the Immune System in Myeloma conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question and answer session. If you'd like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you'd like to withdraw your question, press the pound key. Thank you. Susie Novus, President of the Myeloma Foundation, you may begin your conference.
Thanks, Blair. Good evening, everyone. It's my pleasure to welcome you to the IMS Living Well with Myeloma teleconference series. Tonight's teleconference, as Blair mentioned, is Understanding the Immune System in Myeloma. And who better to explain it to us than Dr. Brian Durie? Before we get started, I think that some people might have been having some trouble accessing the slides, so I'm going to tell you now how to do that. Just in your browser, type in immunesystem.myeloma.org. So that's immunesystem.myeloma.org, and then you'll see a little thing right there that pops up. It says click on View Slides. So it's pretty simple. So March also is Myeloma Awareness Month, and tonight's program is just one of the many activities that we have going on this month. And I'd like to thank all the people out there who are being active and raising awareness not only this month but throughout the year. Many of you participating in walks, marathons, and all kinds of activities, and it's just been great. I'd like to give a special thank you to all the support groups who do such a wonderful job and are making the most of March to raise awareness in a variety of ways. I'd also like to remind you to please visit our website, and I want to direct you to something new. If you go to www.myeloma.org and then click on Myeloma Voices, you'll listen to some very powerful and inspiring stories that patients and caregivers have shared. It's really wonderful. And also, don't forget that our next Patient and Family Seminar will be held this next weekend, March 27th and 28th in Redwood City, which is just outside of San Francisco. There's still time to register, so if you want to come, just call us at the IMS at 800-452-2873. And I'd just like to take a moment to thank tonight's sponsors. We couldn't do it without them, so I'd like to thank Bristol Myers Squibb, Celgene Corporation, and Takeda Oncology. This is a very important topic because myeloma has a negative impact on the immune system. So we need to learn what we can do to not only protect our immune system, but to boost it. And that's what Dr. Durie is going to do, walk us through this very important topic. So I'm sure you have a lot of questions, and I want to remind you that our info line is here to help. So that toll-free number is 800-452-2873, and it's open Monday through Friday, 9 a.m. to 4 p.m. Pacific Standard Time. So, okay, Brian, it's all yours.
Well, thank you so much, Susie. It's my pleasure to have a chance to discuss the immune system from Los Angeles, where it is, as you can see on my cover slide, a beautiful evening. I was about to say summer evening. It feels like it might be summer, but actually it's still spring. A beautiful evening here. If you go to the next slide, and you will notice that the slides are numbered this evening, so if you go to slide number 2, you'll see that I have a headline, "The Immune System is like a Swiss watch." And I think that this is an important analogy in that your immune system is extremely important. Myeloma is a part of that. Myeloma is actually a cancer of the plasma cells, which is part of the immune system. And so that when you change one part of the immune system, it really does have an impact on all of the other cogs and wheels that are part of your immune system that keep things in check and in balance. And so if you change the T cells or the B cells, it impacts the plasma cells. And so we need to be very much aware of that. It's like tweaking a very delicate system when you want to modify or enhance the immune system. So if you go to the next slide, slide number 3, you'll see that I've summarized what are the cells which are part of the immune system. And so many times we talk about chemicals and cytokines and things like that. Tonight I'm mostly going to be talking about cells, and you can see on this slide that there are several slides which are part of your immune system. obviously the central cell compartment is the B cell compartment. And so B cells are the cells that, as they mature, they turn into plasma cells. And normal plasma cells are the cells which make the antibodies to fight infection. And so this is a key part of your immune system. And so normally, plasma cells are really the good guys. Now, regulating and modifying this kind of an antibody response are the other cells, the T cells, the natural killer cells, the monocyte macrophages, the dendritic cells, and the stromal or fibroblast cells. And these can have different regulatory effects on the plasma cell B cell axis, so that normally, for example, dendritic cells, many of you have probably never heard of a dendritic cell. What in the world does that do? Well, dendritic cells pick up the antigen. So if you get pneumonia, the dendritic cell would pick up the antigen from the pneumonia bacteria, and it would present it to the immune system so that the plasma cells would end up making antibodies against the pneumonia. Now, in regulating that process, the T cells and the natural killer cells and the monocytes are very, very important. In fact, the macrophages break down the pneumonia and present the antigen that basically give the antigen over to the dendritic cells, and then the T cells and natural killer cells modify the immune response. So you can see that under normal circumstances, all these cells are working closely together to give you a balanced immune reaction when you have an infection. So if you go to the next slide, which is slide number 4, I've summarized this, where on top I've got what happens normally. You get pneumonia, the B cells get triggered, the plasma cells get boosted up, and they make the antibody against the pneumonia. Now, normally most people will get over the pneumonia in 1 or 2 weeks. What happens after that is that those plasma cells go through a process which is called apoptosis, which means that they break down naturally and mostly disappear, and you're left with just a few memory cells. Now, the big difference in myeloma is that there is a triggering antigen. Many times we don't know what that antigen is, and many patients are anxious to know, well, what is it that has triggered my myeloma? Sometimes, occasionally, we do know. I have one patient with who has also AIDS, for example, and we discovered that the antibody in his case was actually against the AIDS virus. And so in his case, strangely enough, the AIDS, the infection that was a problem for him, had actually been the triggering antigen. But many times we don't know what the antigen is. But the big difference in myeloma is that after 2 or 3 weeks, the cells, the plasma cells, they don't disappear. They actually persist and they build up, and they, over time, give rise to the myeloma. Now, you'll see another word there, which is idiotypic, and that word means that this is a very particular type of a plasma cell which is producing the very particular type of monoclonal protein. And so when we say idiotypic, that links to that word monoclonal. And so this means that these plasma cells are part of the monoclone that gives rise to the myeloma. If we go to the next slide, number 5, this illustrates how myeloma evolves over time. And so if you look at the left, as we've learned, myeloma virtually always does evolve from MGUS, monoclonal gammopathy, which is on the far left. And you can see at this stage, the cells are dividing slowly, and then after there are several subclones, you can get that red one there, which is a cell which is what we call has undergone a second hit, where suddenly it's not just growing slowly, it's growing more actively and is turning into myeloma and can give rise to what we call a dominant clone which takes over. Now, there's another process happening which is called clonal competition. And so the clone that takes over is competing with the other ones, and it takes over, and the end result is that the other clones get suppressed or shut down. And so, as I'll show you on the next slide, what happens is that the normal plasma cells, which are making antibodies against this, that, and the other, are reduced. And so the normal IgG, IgA, all the different normal immunoglobulins are reduced as this dominant myeloma clone is increasing and requires therapy, which you can see with that green arrow in the middle. Over time, the different clones will come and go. Many of you have seen the slide which shows what are called the clonal tides, where one treatment can make the clones go away and then another clone can pop up later. Now you can see at the bottom, I have one possibility is that the small blue clone on the bottom left can be kind of hiding there, and it can be the one which can be the most dangerous later in the disease. And so we are now aware that there are these multiple clones or subclones which are competing against each other, and they're also being regulated by the immune system. And so if we go to slide number 6, I break that down in a little bit more detail, and I hope that this will clarify things a little bit, how myeloma messes up your normal immune system. Well, if you look at the myeloma on the right, you'll see that the myeloma is actually being fed by the stromal cells, which adheres to the myeloma actually and triggers it to grow, and the macrophage actually makes a number of growth factors which make the myeloma grow more, and that's why you have those green plus signals. But as the myeloma is growing and as the macrophages are active, they are triggering some suppression of the normal B cells and the normal plasma cells, and so it's through those factors that the normal IgG production is reduced. And so this is one of the things that happens as the myeloma is building up and growing. As we go to the next slide, slide number 7, this is the way that slides often look at when we're talking about how do we treat myeloma. You've got that big yellow circle, which is the myeloma cell. And as I say there, the bone marrow microenvironment. Wow, a lot going on, that's for sure. Well, you'll be glad to know that tonight I'm not going to talk about stuff inside the yellow circle. I'm going to talk about how the different cells interact with each other. And so what I'd like to focus on actually is the green blob down at the bottom left. This is something which is called a BMSC, which you can see in blue letters. That's the bone marrow stromal cell. And so you'll see if you look along the top edge of that the green cell, you'll see that it's got 2 green boxes there, and it's also got kind of a pink triangle. And you'll see across from that there are a couple of boxes, and then there's something that could receive the pink triangle. And so these are receptors which bind the 2 cells together. And so there is a process which is called adhesion. And so that when cells come in contact, if there are these matching receptors, they will adhere to each other, and then when that happens, it triggers growth. And so this illustrates how the bone marrow stromal cells can actually trigger growth. Now, what's also important is that you'll see on the coding that that green box is called ICAM1. And if you look later, you'll see that we have antibodies against ICAM1, so we can actually block that adhesion. And so that's one of the ways that we can treat myeloma, by blocking the feeding factors. We can block it from getting that adhesion from the bone marrow stromal cell. If we go to the next slide, I expand upon that to show you some of the other reasons of why myeloma grows. You'll see over on the right, I do have that stromal cell. I have it in kind of a yellow-orange color, and you'll see I also have the macrophages. So those are things which are triggering or feeding the myeloma. You can see on the top, you've got the blue cells and the green cells. The blue ones are the T cells, and the green ones are the NK cells, the natural killer cells. Now, normally, they should be shutting down the myeloma, but as the myeloma is growing, that is blocked factors are produced which block the NK cells and reduce them, and also block the T cells. And so you can see right here there are several ways to possibly treat the myeloma. As I said, you could block the stromal cell from interacting with the myeloma, stop it from adhering. That would be a good way. You could also try to help the NK cells to work better by getting rid of that block. And you could also get rid of that block on the T cells. And so right there you've got three types of strategies of how we see that the myeloma is growing, sneaking through, undercutting the immune system, but also how we could target therapy to correct that. If you go to the next slide, I've summarized what are the major ways in which myeloma impacts your immune system. As I've said, the normal immunoglobulin production is reduced. There are effects on the T cells, where cells which should be regulating the myeloma growth but are not doing their job are actually overreacting, and that is actually a problem. There's a lack of cells which can specifically kill the myeloma, and those are cells which you'll see in literature are called TIL, tumor-infiltrating lymphocytes, and those are things that are lacking. And there's been a lot of work with those cells over the years, and in fact, there was a huge program at the NCI for many years where those cells were gathered up, grown in the lab, and given back to the patient to try to give them more T cells to fight the cancer. And so this has been a big area of research over the years, in fact. But also, helper T cells are blocked, and one of the things that we're going to talk about is that the natural killer cells are reduced in number, and their activity is also reduced. So this is an effect and also now an opportunity. If we go to the next slide, number 10, so how can we recover immune function? As I've said a couple of times, it's very complex, and so we need to be careful to not overdo it. We need to be able to retweak the myeloma. And strangely enough, there's a temptation to want to just boost your immune system. And I can't tell you how many times patients have said to me, just if I could just boost my immune system, that would be the way to go. Well, strangely enough, the way to really get your myeloma under control and to help your immune system is to treat the myeloma. When you reduce the myeloma, these effects that I've been describing are improved and get better. As the myeloma gets lower and lower, the suppressive effects on the T cells and the NK cells and the immunoglobulins gets better. And so actually, treating the myeloma is a really, really good way to recover your immune system. Now, in addition to that, what is very interesting is that we can now enhance the immune system and reconstitute it in a number of different ways. And so for the rest of the talk, I'm going to be talking about these ways that we can tweak and manipulate and improve the immune functioning. If we go to the next slide, I've summarized the ways in which we can do this using different types of immune therapy. So slide number 11. There are three categories here. First of all, we have quite a few monoclonal antibodies, which I'm going to show you, which can directly attack the myeloma. And this is kind of a cool way to go because it's an immune therapy, but it's also directly attacking the myeloma, which, as I've said, will allow the myeloma to recoup itself in terms of the immune system as well. So that's really good. Now, we can also enhance the good immune cell activity. And what I mean by that is that we can make the NK cells work better. We can get T cells, which are needed to fight against the myeloma cytotoxic T cells. We can get them to be built up and work better. We can also get those dendritic cells to be more specifically active. As I said, these funny-looking dendritic cells with the sharp points, those actually present the antigen to the immune system. And so this is where vaccines can work, where vaccines give the antigen to the body, and it can be picked up by the dendritic cells. You can actually give dendritic cells loaded with antigen to a patient and have that trigger the immune system to specifically develop an immune reaction against the cancer, in this case the myeloma. You can also do different things to modulate the macrophages. It is possible, and several studies have been going on, where you can gather up the different kinds of cells, the T cells, the dendritic cells, or the NK cells. You can grow them up in the lab, and you can trigger them. You can do genetic engineering with them. And then once you've grown up a lot of them, you can give them back to the patient. And in fact, some of you may be aware there has been a recent study in Arkansas where they were, Dr. Van Riet, he was growing up NK cells and he was giving them back to patients to see how helpful that would be. And we've talked separately about something called CAR T cells, where T cells are taken out by the group in Philadelphia and they're engineered and then given back to try to wipe out the myeloma. And in chronic lymphocytic leukemia, this has been dramatically helpful, although we're still waiting to see which type of method would work the best in myeloma. And so if we take these one at a time, I want to show you how does a monoclonal antibody attack the myeloma. And the one that many of you have heard the most about is the monoclonal antibodies which are against CD38. So this is anti-CD38. Now, there are 3 medicines which are anti-CD38. So CD38 monoclonal antibodies. If you look at the bottom right, you'll see that I've listed 3 drugs. So there's Daratumumab, which is from the J&J company. There's the SAR compound, which is from the Sanofi company, and then there's MOR202, which is actually from Celgene. These are 3 anti-CD38 monoclonal antibodies. Mostly we've seen so far studies in patients with the first 2 of those. And what I'm showing you in this slide is actually the mechanisms of action for Daratumumab, very similar for SAR. 6 ways. Isn't this amazing? There are 6 ways in which the CD38 antibody attacks. It can attack by just linking to the CD38 on the top of the cell. So if you look at number 1, you'll see the green is the antibody and the blue is the receptor on the top of the cell. And then you can see the lightning. The lightning bolt comes when the antibody links the receptors together and then it attacks the cell and leads to the destruction of the cell. It can do it directly in number 2, where it doesn't need 2 receptors. It can do it just with 1 receptor, which is great. Then you can see, if you go around, there are several different mechanisms. I want to draw attention to numbers 5 and 6, where the macrophages are triggered, and then the NK cells are triggered. You can see different words there that you maybe will hear about: ADCC, antibody dependent, so it's an antibody dependent cellular cytotoxicity, so that it brings the NK cell in to attack. ADCP, number 5, antibody dependent cellular phagocytosis. That means that the macrophage actually eats up the myeloma. Pretty amazing, really. And so you can see that there are several ways that these antibodies work and can be helpful in attacking the myeloma. If we go to the next slide, number 13, you can see what has happened with patients. And so this is from a trial that was presented at ASH, and it shows you that at the lower doses, which is on the top in the red and the gray, at the lower doses of the antibody as they were starting out with the Daratumumab, the myeloma was knocked down, and in fact you can see that the level of the protein went up a little bit in these patients, giving what we call PD, progressive disease. But you can see as you move to the right, and then you get into the blue and the pink and the green, which are the higher doses, that we saw much more evidence of response. And so we see that it's dose dependent, and we're really very, very encouraged that this is giving what we call direct single agent activity, which is dose dependent. And there are many trials going on with this, and it has fast track, which means that the FDA has agreed to review the data right away and see if it might justify an approval, and we're actually hopeful that this could occur later this year. So very encouraging data with this monoclonal antibody, as well as very similar data with the SAR compound. The MOR202 is a bit further behind, much more limited patient data so far. If we go to the next slide, I've switched gears to something completely different. So how do we make the natural killer cells work better? This is slide number 14. And we can see that this is how Elotuzumab works. Now, you may have heard of this drug called Elotuzumab, which is, you'll notice that these drugs, which are monoclonal antibodies, they have MAB, M-A-B on the end, which means monoclonal antibody. And so this is a monoclonal antibody against something called SLAMFZ, which sounds pretty vicious, sounds like it could be a good way to go to get rid of the myeloma. Now, when the Elotuzumab links with the SLAMFZ, now SLAMFZ in this picture is a burgundy dot. And you can see that on the left there's a burgundy dot with an arrow pointing at the NK cell, and if you look over on the right, you'll see there's a burgundy dot on the edge of the myeloma cell. And so those are both SLAMFZ. Now, the green is the Elotuzumab, and so the Elotuzumab actually links, and it links the myeloma cell to the NK cell through this receptor called CD16. Basically, all you need to know is that the Elotuzumab helps link the myeloma to the NK cell. Now, over on the left, you'll see that when the Elotuzumab binds to the SLAM7 on the NK cell, it activates it. And so it activates the cell so that it releases chemicals which can destroy the myeloma. So basically, it's a 1-2 punch. The myeloma cell is held in place, and then the NK cell has an opportunity and is triggered to release chemicals which destroy the myeloma. And so this is really a very cool way to have a new way to attack the myeloma. Now, it was kind of disappointing that although this is the case, the Elotuzumab by itself did not seem to be powerful enough to do a full job. And so then it became quite important to combine Elotuzumab with something that would do a full job. And so what I want to show you now is the role of combinations. And so what turned out to be pretty interesting in slide number 15 is that the other drugs that we use to treat myeloma actually do have immune effects. IMiDs, such as thalidomide, Revlimid, or pomalidomide, they all actually do enhance these natural killer cells to work better. And so that's pretty cool. And so obviously people thought right away, well, I don't know how right away it was, but they did eventually realize that it could be good to give Revlimid along with Elotuzumab. And a slightly different tactic is an effect from Velcade. Velcade actually works through the dendritic cells and activates T cells, and I'm going to show you a little bit about that. So if we go to Revlimid first, what IMiDs do on slide number 16, you'll see the little blue dots, that's the Revlimid coming in. What it does is it triggers production of interferon gamma, and then interleukin-2 cytokine, and this activates the NK cell. The IMiDs also shut down IL-6, which is a growth factor for myeloma, and so it has a combined effect such that the NK cell has a chance to kill the myeloma better. So you could see right away, if you bring Revlimid together with Elotuzumab, that could be a really good thing in enhancing this NK cell-mediated killing. And so if you go to the next slide, 17, you'll see that this is what turned out to be the case in the clinic. As the trial started with the Elotuzumab, plus Revlimid and Dex, you can see that there turned out to be a dramatic benefit. And this was, interestingly enough, dose-dependent. This could be related to the fact that if you have too much Elotuzumab floating around, it actually could prevent the NK cell and the myeloma cell from coming together. And so it is a dose-dependent effect, but you can see a pretty dramatic effect where you can see this is what's called a waterfall plot. And what that means is, as these blue lines are falling, then the myeloma protein level is falling on the left by 10% and all the way on the right by 100%. And so this means that 92% of the patients had at least a 50%, which is the red line across the middle there, and then there were even some complete or stringent complete remissions from this combination. And so you can see really an interesting and dramatic benefit by combining the Elotuzumab with the Revlimid, lenalidomide, and the dexamethasone. So if we go to the next slide, another interesting part of this is that using this immune modulatory approach by combining the three drugs together, what we're seeing is a remarkable prolongation of the remission, what we call prolonged progression-free survival. And you can see the impact of the two doses there, 10 milligrams and 20 milligrams, and you can see that the green line, which is the lower dose, is actually higher than the yellow line, which is the 20 milligram dose. And so this was interesting to see that there's a definite dose effect and that for some reason the 10 milligrams seems to be better. And you can also see, if you look along the bottom, that those lines are looking pretty good out to 33 months, which is close to 3 years, and those lines are continuing to go out there, and so everyone is waiting to see the final results of this trial during this year, where there's indications that the remissions are really lasting quite nicely, and this could be because of this kind of new approach where the immune system is being activated and is sustaining the myeloma in check for a much longer period of time. And so this is also kind of a new concept where we have this immune modulation sustaining a benefit against the myeloma. So what about Velcade? Well, this provides another immune modulatory way to attack the myeloma. Now, in this case, the Velcade, which is in the gold color, it has an effect on the myeloma. It actually has multiple effects on the myeloma. I'm only showing tonight the fact that it produces these burgundy receptors on the myeloma, which are heat shock proteins, number 60 and number 90. What happens with that is that these receptors bring the myeloma cell in contact with the dendritic cell, which means that the dendritic cell can pick up the myeloma antigen and then pass it along to the T cells, and so trigger them to be active against the myeloma. So you have a loop established. And so the Velcade, as one of its functions, can improve the T cell activity against the myeloma. And I put an arrow in there at the site of the dendritic cell to show that this could be enhanced by combining it with a vaccine, actually. This would be an ideal kind of a combo, and so people are definitely looking at that. So I don't want to give you too many details this evening, but also I want to give you a flavor of the number of different ways that we could tweak this system and gain benefit. If we go to the next slide, the bottom line summary here is that you can see pretty clearly many drugs have immune effects, combinations make sense, and so hopefully this is making sense for you and you're seeing the indications of benefit. Another antibody is against something called PD-1, and this was a very hot topic for discussion at our last ASH meeting, actually not because of myeloma, but because of another blood cancer called Hodgkin's disease, and this anti-PD-1 had a dramatic benefit in patients with Hodgkin's disease, and so now there's interest to see whether it maybe could have some important value in myeloma. On this slide, you have what happens normally. Normally, as I've been saying, the plasma cell, in what would be called the target cell here, is under the control of the NK cells and the T cells. And if they're not working, then the myeloma can grow. It escapes. And so this escape is partly a result of this PD-1. And so if we could block this PD-1, we could get the myeloma back under control by activating the T cells and making the NK cells work better. And so this is another example of where an antibody could possibly do the job. What we're starting to learn is that these different antibodies seem to be specifically working well in certain cancers, where CD38 seems to be particularly good in myeloma. Also, the SLAMFZ with Elotuzumab, those seem to be especially good in myeloma. PD-1 seems to be super good in Hodgkin's disease. And so what we need to do is evaluate all the different antibodies and see what might be particularly good for myeloma. If we go to the next slide, you'll be, I think, probably amazed to see what are the current antibodies that we have available. And we actually have an amazing number. On this slide of current options, slide number 22, you'll see on the bottom left in the gold box, I've listed the Elotuzumab, which is going against CS1, which is another name for that SLAMFZ. You can see the Daratumumab and more going against the CD38. But you can see all these other numbers. You'll see, if you look over on the right-hand side, the ICAM1. Now that is that green box that was linking the stromal cell to the myeloma. There's an antibody for that. You can see that the PD-1 is there. You can see that several antibodies that are moving forward in trials are there. You've maybe heard of the antibodies, which is a slightly different mechanism, the anti-CD138, which is different than the 38. So a number of different antibodies that we are testing, and we don't know, maybe a combination of a couple of antibodies could do a fantastic job. But really, really exciting to see so many and the potential for dramatic improvement. So if we look at what happens to your immune system when the treatment is successful, and I do hope that you like the bobbleheads, you'll see on this slide that I'm pretty depressed at the diagnosis when those immunosuppressive cells are shutting down the immune system, but get pretty happy when patients have survived for 10 years and the immune system has gotten boosted back up. And it's been helpful to study, well, what is the status of the immune system in those good survivors at 10 years? And we have found that in those survivors, the immune system is definitely a whole lot back to normal. Not 100% normal, in fact, they never really go back to normal. They actually return to something that we could call a unique immune signature, which means that the immune cells have recovered somewhat, but not 100%. And they've also got some unique features. If we look at the top, under the reconstitution there, you'll see that I list T4, T8, and then something called TH with IL-17. And this is a particular feature of patients who are doing well. They have a buildup of these T helper cells, which make interleukin-17, which is a cytokine. Now, this may get to be pretty crazy for you, but you just need to know that there's some special T cells that pop up and are linked with this better survival, and this is another opportunity. Can we boost those? Maybe we could take those out and grow up more of them and give them back. There are many possibilities. The NK cells have recovered somewhat. One thing that is quite interesting and important is that the normal B cells and the normal plasma cells do recover when you get rid of the myeloma. And this explains something that we've noticed in the middle there, as there gets to be an excellent response, particularly after transplant, that we get these things which are called oligoclonal spikes. And what that means is that they're like little baby spikes in the serum. And this is often a worry because patients are concerned that maybe the myeloma is coming back. But then we discover that the spike is not the same type as the myeloma. And it may be, if you have IgG myeloma, the spike is an IgA. And that's because it's just a reflection of the fact that the normal immune system is struggling to bounce back and is making often a number of little baby spikes that will persist for a few months after transplant, and then they tend to go away over time. And so you can see that the B cells and plasma cells recover, the T and NK cells recover, and then to some extent the macrophages and dendritic cells also the same. So this is an important area to study. It's an important area to be aware of, and also to think about ways that we could enhance it or take advantage of it. And so, moving towards the bottom lines here, what does all this mean? Well, clearly, I hope that you can agree the immune system does matter. One particular point I would like to draw your attention to is that these antigens that are on the surface of the myeloma occur independently of the fact that there might be high-risk features inside the myeloma. That big yellow blob that I showed you at the beginning could include abnormal chromosomes with a 17p, the T414, or 1q+, and that would mean that the cells are more difficult to eliminate using our traditional Velcade Revlimid combos or something like that. However, the immune antigens on the surface of the cell occur independent of that, and so we can take advantage of that to attack cells which might otherwise be resistant to our other methods. And so we have to learn how to sequence and to combine these immune therapies with the other therapies, but it's clear that we could have a significant added advantage. And so, what are the opportunities? Slide 25. Immune modulation early. What I mean by this is that if we can come in at the earliest stage, and Daratumumab and Elotuzumab are being studied in this early phase at the MGUS smoldering myeloma phase, as the immune system is starting to be disturbed early on, maybe we have an opportunity to tweak it back to normal and bring the myeloma back under control. So early immune modulation, definitely an opportunity. Combinations to get more elimination of the myeloma, you could see that right away, could be helpful. And then the third one is, if you had an excellent response, maybe using the immune system to get rid of that little bit that's left to achieve an MRD negative, that could be really helpful, especially as part of our Black Swan project, where we're looking to try to get rid of all the myeloma and hopefully ultimately cure the disease. And so if we go to the next slide, it's helpful to look at what happens over time. And so over a period of years, if the treatment is working, you can see how well you're doing. If you look at the curves that go all the way down to the bottom, you can see that over time, the amount of the myeloma that's left is very, very low, 10 to the minus 6, 1 in a million cells left is the myeloma, and we're picking that up if it's there, we're using our next generation flow method. But you can see that if we do find low levels of disease, this could be an opportunity for immune therapy. We could give these immune approaches to get it down into that negative range, so the myeloma is not going to immediately bounce back up. And so this links in with what we call the Black Swan three-step approach. Early diagnosis, see if we can get some help there. Assess MRD, study the disease. If it's got these CD38, the SLAMFZ, or some of these others, we could use immune therapies in addition to Velcade, Revlimid, and some of our other drugs. And then we obviously do need clinical trials to see if we're doing a complete job and eradicating the myeloma. But the immune approaches are very, very exciting as things that we can add in to this three-step approach. And if we go to slide 28, we can see that there are specific areas where we can have benefit, and I've highlighted them in a maroon color. As you're moving through the pathway, for example, if you have given excellent treatment and the MRD test is negative, is it safe to stop? Maybe you need to give immune maintenance for a year or 18 months. This is something that we're going to study, but this could be an excellent way to sustain the response. If we look over to the right, you can see that if someone has progressive or resistant disease, as I've said, adding in immune therapy as part of therapy against resistant disease could be a way to go. So several points in the disease, several ways to attack the disease and take advantage of the immune approach. So as we look to the future, the bottom line, understanding the immune system matters. Coming up with the best immune therapy certainly matters. And just from what we know already, understanding and treating using immune approaches can be key to better and longer remissions, and we certainly hope could lead to a cure. And some people talk about how this could create a whole new field of therapy called immuno-oncology. I don't think we're quite there with myeloma yet, but we are certainly impressed that immune therapy can make a difference and is going to be increasingly important as we move forward. And so that is the end of my formal presentation this evening. I hope that has been relatively easy to understand, and I'm very happy to take questions that you might have. Thank you so much.
Your first question comes from the line of Gary Riches. Your line is open.
Thank you. I'd like to know, I've been given every 3 or 4 months an IVIG to boost my immune system, and I'd like to know what the doctor thinks of that.
Okay, Gary, glad to help. The IVIG would be basically a replacement therapy. As I was saying, that the normal IG is suppressed because of the myeloma, and sometimes your normal IgG is so low that you can be at risk of infections. And I suspect that did you have some episodes of infection in the past that were worrisome?
Yeah, that's why I kicked in, had pneumonia and some other upper respiratory. Ever since they started the IVIGs, it's helped a lot, yes. So, no, this is not true for everyone, but there are definitely a number of patients who have these recurrent infections and the IgGs are low, and really the only way to decisively help with that is to replace with these IV gamma globulin every few months. It is very helpful. As you may also have noticed, it's unfortunately extraordinarily expensive. Your insurance company almost has a heart attack when they get the bill, but it is remarkably effective. But it just emphasizes the fact that if we have better treatment against the myeloma and your natural IgGs can come up by themselves, this can mean that you don't need to do this. But this is certainly an effective thing to do when
necessary. So hopefully that's helpful.
Your next question comes from the line of Brenda Stubbs. Your line is open.
Hi, Brenda.
Hi, thank you for taking my question. I basically had the same situation that the man before me had. I have been smoldering for about 15 years, and I am 78 years old, and I have been treated with 20 grams of IVIG for almost 3 years, and it has really done a great job of keeping me from getting infections, which I had been getting multiple infections before they started it. So I just wanted to know what you think about, at my age, should I even consider any of these drugs instead of the IVIG?
Well, this is certainly something that we would hope that we can start to be offering more. We are looking at earlier treatment in the smoldering phase, and we do have some relatively simple options. As I was indicating, if we treat the myeloma, so if we were to give you, for example, Revlimid and low-dose dexamethasone, which would probably be pretty well tolerated for you, this could get the myeloma under control and could be a simple way to get your immune system back on an even keel where you don't need to be taking these IVIG periodically. And so also we could have some immune approaches. As I said, the Daratumumab is also being tested in the smoldering myeloma patients. So I think the good news is that we have a new menu of options for people like you versus just taking the IVIG to reduce the infections. Yeah.
Thank you.
Oh, yes.
Your next question comes from the line of Jack Aiello. Your line is open.
Good evening,
Hi, Doc.
Jack.
How are you? This was a terrific presentation. I'll probably listen to it 2 or 3 more times once you put it up.
No problem.
A bunch of questions, but I'll ask just one. On slide 17, you showed a waterfall plot of Elotuzumab and Dex.
Yes.
And I want to make sure I'm interpreting waterfalls correctly. To me, it looks like 60% of those green bars go all the way down to minus 100, which would, to me, say that 60% of the people hit a complete response. Am I missing something, or?
Right. So, no, as usual, this is a very astute question. And the answer to that is that you can get down to that level, but the immunofixation and the bone marrow have also got to be negative to give you a complete remission. So if either one of those are still positive, it turns out to be a VGPR versus a CR. And so that's why you've got those 17 VGPRs, where the bone marrow still had some plasma cells above 5%, etc. And the immunofixation was probably, I don't have the patient-by-patient detail, but that's the explanation.
Okay, thank you.
Okay, no problem.
Your next question comes from the line of Bruce Kawame. Your line is open.
Hi. I've really enjoyed the presentation. I like the pictures and everything. On slide 12, I thought I'd need some clarification on that, because I thought the monoclonal antibodies was a count of the actual myeloma cells in my blood sample, but is CD38 a monoclonal antibody?
Okay, so good point. Let me clarify some of those issues. Well, maybe one comment I'll make first is that I am incredibly grateful to my assistant, Diana Wang, who made the slides very pretty this evening, so I really appreciate her help in putting this talk together. As far as monoclonal, the protein which is produced by the myeloma is a monoclonal protein, and so that's the spike protein that's present in the serum and or in the urine. And so that's one aspect of monoclonal. And so technically that monoclonal spike, which is part of the myeloma, it is technically a monoclonal antibody, but the thing about it is it's non-functional. It doesn't do any good. It's mutated, and so the big thing in myeloma is that monoclonal spike is basically worthless protein. So the monoclonal antibody, which is engineered, is called a humanized monoclonal antibody, which is developed as a treatment, is attacking the antigen, which is on the surface of the myeloma. So the myeloma has a bunch of receptors on its surface, of which CD38 is one of them. And so the CD38, in fact, CD38 is the antigen which is the richest. It's the most heavily expressed on myeloma. And so that is why it's a wonderful target. And so the monoclonal antibody is against that, but that's a synthetic antibody humanized to attack that CD38 receptor. And the interesting thing is that when it does that, there are those 6 different things that happen to combine the attack against the myeloma. So, but it is confusing that the monoclonal applies to this treatment as well as to the myeloma itself. So hopefully
that means there's just a lot of different monoclonal antibodies, and
that's right. But the myeloma protein is monoclonal. That's why you have that sharp spike. Yes.
Yeah. Okay. That's why I thought it was the monoclonal antibody. Okay. Very good. Thank you very much.
That is a very important differential point there. So that strangely enough, as was pointed out by Jack Aiello, as the treatment is working, we are tracking the level of the monoclonal antibody in the blood to track how the treatment is working. And in fact, this is a very interesting point, which the J&J company discovered, which is that as we test the blood, and this may link into Jack Aiello's question actually, as we test the blood, the monoclonal antibody, it does show up as a monoclonal antibody, so it interferes with our ability to say that a patient has achieved a complete response, so that when we test the blood, there actually is still a little bit of monoclonal antibody there, which is actually the drug. so the drug is still there, and so we've actually been working with the J&J company to help find a way around that so that it doesn't give a confusing answer, so that we can say that it's not a VGPR and it's actually a CR. So this is a good technical point. Thank you.
Okay, very good. Can I slip one more question in?
All right.
On slide 19, this is the Velcade.
Yes.
And I get the loop and everything, but at the end it says the T cell has a minus. I thought the minus and that was a block. Is it?
Oh yeah, no. So what happens is that in this case, the T cell has been activated so that it can attack. Without the treatment, without the Velcade treatment, it's shut down. So
it improves the attack. I thought that would be a plus. Should that be a plus then, or is minus correct?
No, well, it's negative for the myeloma. You see, there's a green plus beside the T cell. You see that?
Right. Yeah.
So it's a plus for the T cell. The T cell's active, but it's not so good for the myeloma. It's a minus for the myeloma.
Okay.
Which is good.
Very good.
Okay.
Thank you very much. I appreciate that. I'm done.
No problem.
Your next question comes from the line of Evelyn Ehrenreich. Your line is open.
Thank you very much. I have 2 questions. One, you said the immunotherapy might be beneficial for cases of MGUS or smoldering myeloma. Is that still being studied, or are there any recommendations at the current time of when it would be advisable to consider immunotherapy?
No recommendations yet. This is very new. So it's an exciting new area, but really no data yet, and certainly no recommendation yet. So sorry about that, but it's exciting that it's starting.
Right. So the second question, you may also say there's no data, but what I'm thinking is for an elderly patient who's had some treatment, reached a stable level, but if the patient were an elderly, would still be continuing with additional treatment. The treatment stopped due to potential neuropathy and comorbidities and so on.
Right.
Would immune therapy possibly be an option for an elderly patient of that profile while discontinuing the previous
yes.
Velcade with X and Cytoxin?
Right. Good point. So I think that this is one of the situations where we're thinking that because the antibody approach, for example, could work even in resistant myeloma cells, this could be a way to get rid of the myeloma that is left. Oftentimes we've stopped treatment because of side effects and, because these drugs have a lot of toxic reactions and they're not working so well, so there's no value, and so we'll just stop. But if we have a well-tolerated antibody which could really get rid of those resistant cells, that could be a way forward. So that's one of the things that I was illustrating toward the end of my talk, that this could be a very cool clinical trial, actually, for us to see how much value that we could get out of that.
Right, but I guess this is still very early stage.
I know. I'm sorry but these are good suggestions, and you can see the potential here for sure.
Absolutely. Okay. Thank you.
Mm-hmm.
Your next question comes from the line of Janet Anderson. Your line is open.
Yes, thank you, Dr. Durie. My question comes from slide 6.
Okay.
You talk about how that the myeloma is fed by the macrophages.
Right.
And I thought they were the good guys.
Right. Well, very good point. Lots of good points tonight. So the gentleman who discovered the macrophage, Metchnikoff, he wrote a number of articles where he called the macrophage the two-edged sword. Because it can turn in either direction. It can be good and then it could be bad. In the case of myeloma, what happens is that for pneumococcal pneumonia, this is possibly the best example, the macrophages have trouble getting rid of the pneumococcal pneumonia because it's an encapsulated bacteria. So it's got a fatty capsule around the bacteria so that the macrophage gobbles up the bacteria, the pneumococcus, but it can't completely destroy it. And so then it's kind of sitting there, and as it's kind of frustrated and trying to get rid of this bacteria, it's producing a lot of chemicals which actually end up fostering the growth of the myeloma. And so if you have incomplete activity from the macrophage for various reasons, then the persisting macrophage can end up being a feeder cell. So it is kind of a paradox there. And so people have looked at this. There are macrophage diseases. So one question is, how do macrophages kill bacteria? And it's actually because they produce like hydrogen peroxide or superoxide within the cell. And that's how they kill bacteria. But some macrophages could be deficient in that. And we don't understand all the reasons that people get myeloma, but it could be in part because the macrophages are not 100%. They are defective in their ability to produce hydrogen peroxide and superoxide, and so they're not able to fully kill infections. And then they kind of hang around. And in fact, that hydrogen peroxide can be dangerous because if that's leaking around, it can actually damage chromosomes. And there is one theory that because those macrophages are kicking around and releasing hydrogen peroxide, it's actually one of the mechanisms that causes damage to the chromosomes. So there's a little bit of a story there to the macrophages, but they definitely can work both ways.
Would these defective macrophages cause the body to start producing more monocytes to try and make more macrophages that actually work?
That's right. you get overreaction. You're very good deduction, and so we often do see extra monocytes and macrophages for that reason. You're exactly right. So that's why I said that at the beginning I liken the immune system to a Swiss clock or watch, because there's this compensation that occurs, and it can end up being a negative.
Interesting. Thank you very much.
No problem.
Your next question comes from the line of Robert Karp. Your line is open.
Yes, hi, thank you. What is the danger of early treatment of smoldering myeloma with immune therapy killing the good clones, but allowing the resistant clones to start growing more quickly?
Right. So, absolutely, this is a concern, and so that's why we start with trials. I think that we just need to be very cautious about just exactly what I was saying, is that it is like a Swiss watch. Yes, you can do what you think you're doing, but it could be affecting something else, and those resistant cells that were hiding or sitting there could have an opportunity to grow. And so we just need to take it a step at a time and see what is truly helpful, or what could truly be providing an opening for something. So we move forward with caution. Yes.
Okay, thank you.
No problem.
Your next question comes from the line of Jan Hopman. Your line is open.
Yes, hi. Thank you for taking my call. This is very informative. I wanted your opinion. My particular case, I've had tandem
transplant?
Yes, transplants. And according to my most recent bone marrow biopsy, I have achieved complete remission, and that's been now for 18 months.
Okay.
And I'm not on any maintenance therapy as per my myeloma specialist. And I'm fine with that, of course.
Of course.
How does that affect perhaps a longer remission, longer survival versus maintenance immunotherapy? Do you recommend maintenance immunotherapy for somebody in my position who has achieved complete remission?
Right. Yet another really, really excellent question, and this is actually why this Black Swan project is so important. I mean, I think that we want to be able to get down to those complete remissions, MRD negative, but we want to know, well, is that going to last? Does that fantastic remission mean that the myeloma is never going to come back? Or maybe we need to boost your immune system a little bit to get that last extra step and sustain the remission for a long time. And so it is opening up a whole new area here where, as I said, maybe this is an opportunity to boost those T17 cells, if we could see what's going on. And so we're going to be, I know that many people are going to be looking at this, but we're certainly going to be looking at the immune system in longer survivors to try to understand this and see if we should give something to boost those T cells, or maybe do something a little different to get that maximum benefit and sustain the remission. But again, we would be tweaking, and we need to be safe and understand what we're doing.
Right, as opposed to, doing some maintenance therapy now, and then if the disease were to become more aggressive, run the risk of perhaps treatments not being as effective.
You're exactly correct. So I think that for someone like you, for now, it's a balance, but we would be inclined to watch you closely.
Right.
And then if the myeloma was flaring, maybe an immune modulation approach could be a way to consider, but we would tend to reserve that if we saw a little bit of activity versus now.
Right. Okay, great. Thank you.
No problem.
Your next question comes from the line of Frederick Kushner. Your line is open.
Yes, thank you very much. It's an excellent presentation.
Thank you.
I have an MGUS with a protein of only 1.5 and normal kappas, it's a kappa MGUS.
Yes.
But
okay.
my lenses are suppressed, and my other immune globulins are low. Even though I only have 5% in my bone marrow. Is there anything I could do to improve that situation, or does it have any significance that the other light chain is suppressed?
Right. So this is exactly what I didn't have that on the slide, but I need to put that on the slide so that the suppression is what we call light chain specific. In other words, the immunoglobulins that are suppressed are the ones that are not the myeloma, and so if your myeloma is kappa, then the lambda plasma cells are suppressed, and so it's a light chain specific thing. So this is what we would expect. The other thing is that this is one of the earliest things that happens, and so this is something that many patients with MGUS have this, and so it doesn't mean that the MGUS is going to turn into myeloma, and so it's a feature of this early immune disturbance that's linked in with the MGUS. And as we've been discussing, we need to be a little bit cautious about meddling with that because the last thing we would want is for the myeloma to turn more active. So we tend to accept this immune suppression. The numbers are low, but a majority of patients do not have infections. We heard from a couple of people who do, and so if there are infections or if there's some other problems, we may treat that. You notice that they were not getting treatment for the myeloma, they were getting treatment for the infections. So we might be inclined to replace it or treat it, but we would still be very cautious about jumping in with more definitive therapy unless you really need it in terms of the activity of a myeloma. So I'm sure it's frustrating and kind of annoying to see those low numbers, but have you had infections or other problems?
No infections and no progression of the M protein or the plasma cells.
So I would stick with that for now. But I mean, stay alert. I mean, this field is moving quickly, as you can tell, and so there could be some new options, some new opportunities. It's a new way forward. So I wouldn't do anything for now, though.
So it makes the KL ratio abnormal, even though the kappa numbers are normal.
That's right. And so when we, in our diagnosis and response criteria, when we do our tables, we have lots of footnotes because we have to explain all this stuff and say, well, actually, it could be abnormal, because that other one is low, but it's not indicating that the myeloma is high, and so we need lots of footnotes to explain this stuff.
Okay. Thank you.
No problem.
Your next question comes from the line of Betty Kaufman. Your line is open.
Thank you. Thank you so much for that wonderful presentation. My question is, I had autoimmune hepatitis prior to getting diagnosed with multiple myeloma, which confuses me about using, pumping or doing something with the immune system, because when I started to take the Revlimid, the autoimmune hepatitis went away, and I no longer have a liver disease. But I'm concerned about the consequence of using an immune therapy when my immune system was functioning strangely before I had the multiple myeloma.
Good. Another very good question. And so, as you have probably deduced, it seems in your case that there could be a linkage with the hepatitis. And so I think that it's quite important to talk about this carefully with your liver doctor. You may also be aware that we have excellent new treatment for hepatitis C, which can basically cure the virus, get rid of it with a 6 weeks or 12-week course of treatment. And so if you do have still hepatitis C in your system,
I had autoimmune hepatitis where my immune system was attacking my liver. Yeah, attacking my liver.
But there wasn't a hepatitis identified. No.
Well, the autoimmune hepatitis was identified, and then once I got off the drugs that I was taking for that and started on the Revlimid, a year later they did another liver biopsy, and I was completely free of the autoimmune hepatitis.
Okay. Well, that's interesting. I mean, it sounds like the immune system was attacking the liver for some reason, but I suspect there are many, many types of hepatitis, and so it might be worth just going to a liver specialist just to get double-checked for any type of virus hepatitis that could be in the background. But otherwise, it sounds like the myeloma treatment has taken care of both, which is good.
Right. I'm just concerned if I were to use an antibody or do something to my immune system to help the myeloma, would it cause a flare-up of the other side of my immune system?
Exactly. Well, these are delicate things, so I would stick with what's working. It seems like this is working well, so I would just go with what you're doing. But I think in your case, I would be a little bit cautious about manipulating it anymore. Yeah.
Yeah, thank you so much.
No problem.
Your next question comes from the line of Ian McDonald. Your line is open.
Thank you. Referring to slide number 18,
yeah.
And this is I just want to confirm my understanding. This is a trial that's ongoing, and the green line continues to go out until the trial's over. And I'm making an assumption that the trial is for people that have never had, say, Revlimid before, and now they're taking Revlimid plus the Elotuzumab. And if you've had Revlimid before and have gone through the cycle where it's finally stopped working,
right.
Is there any point of trying again with adding one of these Elotuzumabs or that type of product?
Yeah, absolutely. So the simple answer to that is definitely yes. So this if you notice down by the number 18, I just took the data from the pilot study, which was with the 3-drug combo. Now, what's been happening since then is there's a randomized study, where half the patients are getting the Revlimid and the Dex, and then the other half of the patients are getting the 3-drug combo. And what we're waiting for is to see how much longer the remissions last when you add in the Elotuzumab. Now, there are different studies, Eloquent 1 and Eloquent 2, with the Elotuzumab. The one in the relapse setting is the one that we're expecting to see the data from first. So these are in patients who've had 1 to 3 relapses, and those are patients who may have taken Revlimid in the past. And so we will have a pretty good number of how many of those respond and what the outcomes are in patients who've never taken Revlimid or who have taken Revlimid. But one of the ideas is that adding in the Elotuzumab could make the treatment work when it was not working, or certainly work better. So, yeah. So. Hopefully that helps clarify. This one was one looking at the combination, which led to this discovery that the lower dose seemed like it was equally good, and they ended up using it was counterintuitive. They were thinking that they would go forward in the trials with the 20 milligrams, but they ended up with the 10 milligrams.
Well, thank you very much. That's encouraging.
Yes, no problem.
Kind of opens up the use of the drugs again.
It
Maybe.
Does indeed, yes. And we have this concept with the others. You can give, like Revdex plus Daratumumab or the SAR compound, So it means that you can get more mileage out of the drugs that we have been using. And there's actually kind of a cool concept for a trial, which is coming now with Daratumumab, which is one in which the Daratumumab is added to what's called the backbone. And basically, patients are allowed to take the Daratumumab along with what they have been taking. which is kind of a cool concept where you don't need to stop. You could, if the treatment's not been working that great, you can continue it and then you add the Daratumumab in, which is, I think, kind of a nice structure for a trial. It was presented for the first time by Dr. Philippe Marrow from France at our ASH meeting, and people were kind of excited about that idea.
Well, thank you very much.
No problem.
Your next question comes from the line of Tom Courbat. Your line is open.
Yes. Hi,
evening,
Dr.
Tom.
Durie. How you doing? Thank you for such a great presentation today. I've got a couple of questions. The difference between the Daratumumab and the SAR trial.
Yes.
I was told on the Daratumumab trial that if I previously had Pomalyst, that I would be automatically excluded, and it seems interesting because in following up on the couple of the previous gentlemen's points, where if you had something that you took in the past and maybe it didn't work great, maybe it would work well in this combo. Why would they not allow Pomalyst in the Daratumumab trial?
Well, it's just the structure of that individual trial, unfortunately. I mean, I think that there are different trials, there are different questions that you could ask. As you could see, you could want to know how does Dara work in patients who are not who've not gone through all the different treatments, and got to that relapse refractory point. But from the patient standpoint, this one newer trial, which in California is opening at the City of Hope, I think now or soon, it's kind of cool, where most patients are included or allowed to get in. Yeah. But it's not because it might not work, Tom. It's just because of the structure of that particular trial.
Okay, now in the SAR trial, which I believe is up at USF.
UCSF, yes.
UCSF. Is that how is SAR different from Dara?
It's very, very similar. They're both antibodies against that anti-CD38, but for them to be commercially viable, they're slightly different antibodies manufactured in a different way against what are called different epitopes. But what I'd suggest, Tom, is maybe if you want to call into the hotline, we can try to help you and make sure that you can get into a study that would be most helpful for you, okay?
Okay, and one general question I think would help anybody here, and that is, in addition to tracking your IgG or IgM or whatever and your M spike, are there other elements or factors that you should be tracking so that if you do want to get into a trial, you can give the trial coordinator a timeline, just all nicely laid out in a spreadsheet? What else would they want to know besides your, say, IgG and M spike?
Well, they want to know usually all the different drugs that you've taken, and I'm sure you've probably got a list of that.
Right, of course.
The other thing that they're most concerned about are your general status, which would be your blood counts, your kidney testing, your liver function. They want to know if you had a chest X-ray and you've got any lung problems, and typically they want to make sure that your heart is in reasonable shape, that your ejection fraction is okay. It doesn't need to be normal, but they want to make sure that it's not real low. So those are the sorts of things that would be helpful.
Okay. All right. Thank you very much.
Right. But please call in, and we'll be glad to try to help you get into a trial that works the best for you, okay?
Bye, Tom.
I sure appreciate it. Bye-bye. Thank you so much.
Okay, I think that we've reached the witching hour, and it's been a long call, but lots of questions, and hopefully this has been very helpful to those who've been listening. So I'm going to turn it back over to Susie at this point.
So, Brian, I just have to say that was fantastic. It was quite an impressive talk, and I'm sure that everyone who listened in tonight learned a lot, but I think that they probably have a ton of questions. So for all of you people who are on the call and have more questions, please remember to call our info line. It's a toll-free number, 800-452-2873, and they're open Monday. I'm just going to say Monday and Thursdays are really good days to call because we have 3 people manning the info line then. So obviously there's a lot of questions, and most likely even our info line people probably it's such a technical talk tonight that probably the info line will have to go like everybody else and ask Dr. Durie and then get back to you. So I think the best thing is to make sure that you're very clear with your questions so they can jot it down and then ask Dr. Durie and probably get back to you. So once again, before we close, thank you so much to our sponsors, Bristol Myers Squibb, Celgene Corporation, and Takeda Oncology. And good night, and thanks so much. Remember, the IMF is always here for you. Take care. Bye-bye.
Thank you.